In this lecture, I will talk to you about gluteal region, or what known as buttocks. So let us define the region of the, or let us define the gluteal region. First of all, it's the prominent area. Just you see the shadow of the pelvis here. So it's the, let me check this, okay. So this is the hip bones on the right and on the left. So the gluteal region, the area or the prominent area that's located posterior to the pelvis and superiorly and inferiorly, as you see the dotted line. This is the border of what known as gluteal region. So gluteal region extended superiorly to the iliac crest. I think you remember from the lecture of the bone that this is the highest point there, and inferiorly it extends until it reaches this fold known as gluteal fold on the right and on the left. Anyway, you have to know that this fold, one on the right and on the left, they represent the lower border of gluteus maximus muscle, right? So the gluteus maximus muscle extended inferiorly until this point, and it creates this kind of fold that known as gluteal fold. Now, in between, we have, if we look to the buttocks from posteriorly, you will see this cleft in the midline. This known as natal cleft or intergluteal cleft, because between two gluteal regions, so we call it intergluteal cleft. So this cleft, of course, separates the buttocks from each other. Now, yes, we define the region of the gluteal area, and now let us have a look on superficial fascia, and then we'll talk about the cutaneous nerve supply that area, and then we'll talk about the deep fascia. But first of all, you know that under the skin, especially in this area, you have a large quantity of fat that represent the superficial fascia that gives the prominence of the buttock, you see. And of course, because we sit on the ischial tuberosity, so it creates a kind of, this is the ischial tuberosity, right? This is the ischial tuberosity. So it gives like a cushion over the ischial tuberosity. Now, well, let us have a look on the cutaneous nerve supply the buttock. Here, you guys, you look to the right lower limb, in which I would focus on again on the buttock area, and we will divide it into, I would say, maybe 4 parts, right? So this and a region here, which is the upper lateral quadrant, and here is also the lower quadrant, and here is the upper medial quadrant, and here is the lower medial quadrant. So let us erase these things, and simply the lateral upper quadrant here innervated by the 12th thoracic nerve and the iliohypogastric nerve, which is a branch of L1. That means T12 and L1. Very simple. Now, there is an easy way to remember these 2 quarters. The lower one, laterally innervated by the lateral cutaneous nerve of thigh, but this posteriorly innervated by posterior cutaneous nerve of thigh. The same name, but this is lateral. Of course, this is from L2, L3, right? But this one from the sacral plexus, the posterior one. Anyway, but the same, lateral and posterior cutaneous nerve of thigh. This is the lateral one, and this is the posterior one near the what we call the gluteal cleft here. You see the gluteal cleft, and here is medially. In this corner, you will get from the upper 3 lumbar and sacral nerves, of course, the posterior rami, because you know this the sensation carried to the posterior rami, not anterior. So the upper three and upper three lumbar and sacral, because they are close to this area, so we expect to carry the sensation from this area. Now, the most or the skin of the floor of intergluteal region in the intergluteal cleft or natal cleft. This is simply from lower sacral and coccygeal nerves. Yes, the lymphatics, you are looking to the inguinal lymph nodes anteriorly. So this is anterior, right? So this is the superficial inguinal lymph nodes, two groups, the vertical and horizontal. Anyway, you know, posteriorly, from posteriorly, the gluteal area drains the lymphs into the superficial inguinal lymph node. Which one? Mainly the closest one, which is the lateral group, right? So the lymphatics from the gluteal area shifted anteriorly to the superficial inguinal lymph node in the inguinal region here, and especially to the lateral ones. That was the superficial fascia, cutaneous nerve, and lymphatics. Now let us move a little bit deep. Not the superficial fascia. Now I would like to talk about the deep fascia. And you know the importance of deep fascia in fixing the muscles and dividing the lower limb, especially into compartments. Now, this is, you know, let us start inferiorly. You look into the buttocks posteriorly and to the thigh here, right thigh I was as well. So remove the skin and you see this yellow color, which is the superficial fascia. Okay, remove it. Then deep to it, there is that you look to the green color, which is the deep fascia of the thigh. That's known as fascia latae. Fascia latae. So you can say deep fascia of thigh, or it's you know, it's better to summarize it and abbreviate by saying fascia latae. So the fascia latae ascends up, and let me rephrase it in a different way and say the deep fascia that covers the gluteal area is an extension of the deep fascia of the thigh. So the deep fascia of the thigh will extend up to cover the gluteal region. But the deep fascia or fascia latae, once it reaches this, the lower border of gluteus maximus, because this is the largest muscle in the body, the gluteus maximus, right? So once it reaches the lower border, the deep fascia splits into superficial and deep layer to enclose this muscle, and again, you see it's here, it's removed, right? The fascia latae removed just to show you the gluteus maximus. Now, once it reaches the upper border of this muscle, you see this is the border of gluteus maximus. So once it reaches here, again they unite again to form one layer to cover another muscle. This is the gluteus medius, right? Gluteus medius muscle. So you see the green color. So again, it becomes a one layer to cover the gluteus medius. So it was like that, then split to enclose the gluteus maximus, then unite again to be a one layer to cover the gluteus medius, and all the way until it reaches the iliac crest. This is the iliac crest and attached there. Let me erase these things to show you again. Yes, here's attached. You see the green color here again, attached to gluteus, to the iliac crest, sorry, superiorly. But also not just superiorly and posteriorly, the deep fascia, you know, as you see here, the green color, it extends laterally and thickened here laterally. You see how is the thickening shown here? Yes, and also of course here. So this thickening of deep fascia laterally creates a kind of strong wide band of deep fascia, but we call it iliotibial tract. Ilio because attached to the ilium bone, we'll talk more about that, and to the tibia laterally here. So let me show you where is it. Okay, here's of course this. I will start with this one. Look at the hazy transparent like a membrane, which is the deep fascia. You see here encloses the lower limb and ascends up until reach Gluteus Maximus, splits, enclose it, and then again to cover the Gluteus Medius here attached to the iliac crest. And again, this deep fascia of the thigh and buttock thickened laterally to form this band. You see this band? This band, strong laterally, strong band known as iliotibial tract. Iliotibial tract. Again, here is again, and on surface anatomy, this one. You can see this part, right? Number 9. So just if you are interested also, you can have a look, for example, Gluteus Maximus here, number 2, so match, there is matching between numbers here on the diagram and on the real figure on the middle one. Of course, we talked about the gluteal region. It's a region in our body, so we need there are a couple of muscles there. That means we need bones and ligaments, and to supply these structures there, we need also because muscles, we need innervation. That means there's nerves and of course vessels. So we discussed that in details in a previous lecture about the pelvis and hip bone. So the bones of the gluteal region mainly, including the hip bone, femur, and of course it includes the hip joint. Ligaments. These ligaments, I mean the sacrotuberous and sacrospinous, is like hidden behind this because it's triangular in shape and medial. The sacrospinous is medial to the sacrotuberous. There is a of course in the previous lecture we talked that about those two ligaments and other ligaments related to the sacroiliac joint in details. You can have a look there, but for now, in summary, look here, guys. You remember the bone that we have a greater sciatic notch and lesser sciatic notch here. And in between, you know, those knots created because of the presence of the ischial spine, which is a small spine here related to the ischium. Okay. Now, these knots will be converted, as we mentioned previously, into foramina. They become foramina. The greater sciatic foramen, not notch, and lesser sciatic foramen. Those created because of the closure of those knots by these ligaments, sacrotuberous, in which you know that the sacrotuberous ligament extended from the posterior superior iliac spine and part from the posterior part of the ilium, and of course the correlated or related area of the posterior surface of the sacrum. It's a triangular in shape, and the apex of this ligament, I mean the sacrotuberous from its name, in the ischial tuberosity here. Medial to it we have another ligament also attached to the lateral surface of the lower part of the sacrum and coccyx, and inserted in the spine, ischial spine. It's known as sacrospinous. This one, it should be like here. It's like triangular, small triangular in shape behind this medially. So these crossed ligaments converted the knots into foramina. And look at the direction of these arrows, these arrows give an idea about what's going on. So this arrow comes from the greater sciatic foramina out. That means there are a couple of structures moving out here, and there is another, you see there is a smaller row here that shows a couple of structures come from a greater sciatic notch and again inserted back into the lesser ones, and from lesser ones, of course, you see here. So what I'm gonna say about the structures passing from the greater and lesser sciatic foramina, these things are very important, especially in exams and clinically as well. So let us again define, I think you may be confused, but simply you are looking to the gluteal region posteriorly. This is the greater trochanter of the femur, and here is the anus, and here is the posterior superior iliac spine. So again, this is our ligament sacrotuberous. Let me draw it. So this is the sacrotuberous, but where is the sacrospinous? Here is, you look at it here behind these vessels and nerves. Behind it, there is a small green color, comes in that way to attach to this spine, ischial spine. Now you have an idea where we are. I will use the red, no, this one is better. Okay, so this is, where is the now greater sciatic foramen? Yes, this is the greater sciatic foramen. This is the greater sciatic foramen, and this is the lesser sciatic foramen. Okay, what are structures passing from the greater sciatic foramen? Well, the structures passing from a greater sciatic foramen can be divided by an important muscle pass from there also, which is the piriformis. You see the piriformis muscle? Piriformis muscle. This is the piriformis muscle. So the piriformis muscle, we'll talk more about it. It divides the structures basically from a greater sciatic foramen into structure above it and structure below it. So above the piriformis, there is a superior gluteal artery and nerve. Superior gluteal artery and superior gluteal nerve, the same name, artery and of course vessel and nerve, superior gluteal artery and nerve, superior, above the piriformis. Now that means there is inferior gluteal artery and inferior gluteal nerve as well. So let me erase these things, so now you will get per view. So that means above the piriformis muscle there is superior gluteal artery and nerve, and below it there is inferior gluteal artery and nerve, of course. It's very simple. What else? Below the piriformis there are also many structures, including one important nerve, the longest nerve in your body, which is the sciatic nerve. This is the sciatic nerve, right? And another nerve we mentioned that in the cutaneous nerve of thigh, the posterior cutaneous nerve of thigh. What else? You have here the pudendal nerve. This is the pudendal nerve. And you have, other than the pudendal nerve, internal pudendal vessels, the same name, not pudendal nerve, but internal pudendal vessel. Furthermore, you have a nerve to the Obturator Anternus. So these, of course, there is another one, there is a nerve also here, but not shown here because it's more anterior to all of these structures. So it will be like a dotted line to the Quadratus femoris muscle. You see this muscle? There is a nerve, comes from there until it reaches to it. So it's called nerve to quadratus femoris. So these are the structures passing from the greater sciatic foramen, and I would like at the end to summarize it and say, yes, from a greater sciatic foramen you have piriformis muscle, and above it you have superior gluteal vessels and nerve, and below it there is inferior gluteal vessels and nerve, plus you have the largest nerve, which is sciatic nerve, and you have posterior cutaneous nerve of thigh because you are looking posteriorly, plus you have pudendal nerve and internal pudendal vessels, plus two nerves, nerve to obturator anternus and nerve to quadratus femoris. But now the easier one, which is the lesser sciatic foramen. Well, very simple, very simple. Let me, before I erase it, very simple. You remember these three structures, the pudendal nerve, the internal pudendal vessel, and nerve to obturator anternus. Yes, these structures exit the superior sciatic foramen and get again into lesser sciatic foramen. That means they come out from a greater sciatic foramen and enter again into the lesser one. So this is greater and lesser. So these structures, as I mentioned, passing out from the greater, then enter the lesser sciatic foramen. Plus, of course, let me show you here. It's not a piriformis, no, piriformis was above. Here's, you see the obturator anternus here, the tendon of obturator anternus. So it comes from here and passes through this area. So there is a tendon pass from the lesser sciatic foramen, the tendon of obturator anternus. So similar to the piriformis, but here is obturator anternus, the tendon of it. So these are very important, and these are the structures passing through the greater and lesser sciatic foramina. And now the time for muscles. You can say that we have almost about 9 muscles. Here's the Gluteus Maximus, the largest muscle in your body. Just remove it. When you remove it, you will get this view in which you have a Gluteus Medius cut in here, right? And below it you have a Gluteus Minimus. So you have a Gluteus Maximus, Medius, and Minimus. Plus you have an important muscle. We already mentioned it in the greater sciatic notch, which is the Piriformis muscle. Excellent muscle, I like it. And also you have two sisters. One is the superior gemellus and one is the inferior gemellus. So both gemelli separated, two sisters separated by this muscle, obturator anternus muscle. So plus, of course, most inferiorly you have a quadrangular muscle, which is like this shape, this muscle, which is the quadratus femoris, not quadriceps femoris. No, it's quadratus femoris. So let us start with the largest muscle in your body, which is that known as Gluteus Maximus. This is the Gluteus Maximus. Really, it's a huge muscle, good site for IM intramuscular injection, and it forms the prominence of the buttock. The origin of this muscle is pretty easy. I think you remember again from the gluteal surface of the bone that we have 3 lines. You have the anterior gluteal line, you have inferior one, and you have the posterior, say this one, posterior one. So the Gluteus Maximus originated from the ilium, as you see here. Where exactly? Just posterior to the posterior gluteal line, and also it originates not from the ilium posterior to that line, but also from the sacrum and coccyx, plus, if you remember, the sacrotuberous ligament, right? So this is the origin of the Gluteus Maximus. Now What about the insertion? Usually, you know that origin comes from the stationary or fixed part, and the insertion in the movable or the part that has more movement. So this is the insertion of a gluteus maximus that inserted in the iliotibial tract. If you remember the iliotibial tract, which is the lateral extension of deep fascia in the thigh, plus to the gluteal tuberosity. Now, this is the origin and insertion of this great, huge muscle. And what about the nerve supply? Yes, don't be confused when you mention the nerve supply for gluteus maximus. It innervated by inferior gluteal nerve. Inferior gluteal nerve, not the superior, the inferior gluteal nerve. Now, most importantly, the function of this muscle. This muscle, if you know the origin and the insertion, you can imagine once contracted, it will extend the hip joint. That means move the thigh posteriorly, because you see the insertion and the direction of the fiber. This is number one. So it extends, and because it attached to the gluteal tuberosity and the iliotibial tract, so once contracted, it moves the femur laterally. So it extends and it laterally rotates the hip joint. Plus, because it inserted in the iliotibial tract, when it's contracted, it extends the knee here, right? So it extends the knee and gives stability for both the hip joint and the knee joint. Now, what I want to mention here also about the gluteus maximus is it's the chief anti-gravity muscle of the hip. What does it mean? It means it's extensively used when you standing up from sitting position. When you're standing up from sitting position, for example, you're sitting in position and when you stand up, try to put your hand on the gluteus maximus and try to get up from the chair. You will see, you will feel that it's really contracted. Plus, not just standing up from sitting position, but also in running and in climbing upstairs. Try all of these things. But during the casual walking, it's briefly used. Try to walk usually casually like normal walk, and you will see that's briefly used. But it's not used at all when standing motionless. If you stand without any movement, you will find that it's really not being used. As we talk about gluteus maximus, I think it's good to mention that you guys don't sit on your gluteus maximus. Yeah, maybe you're surprised, but you have to know that you don't sit on your gluteus maximus, because when you flex, when the thigh flexed, when the thigh flexed, the gluteus or the inferior border of gluteus maximus moves superiorly, leaving the ischial tuberosity here subcutaneous. And in this case, you are, of course, sitting on the ischial tuberosity that's, of course, covered by ischial bursa here and fatty fibrous tissue. So jumping to the another muscle which is deep to it, which is the gluteus medius. Well, if you look at it, the gluteus medius, you can see it here, but I think you will not be surprised if I will tell you that the gluteus maximus covers all the gluteal muscles except the superior anterior 1/3 of the gluteus medius. Gluteus medius is larger than that, right? So the gluteus maximus doesn't cover the anterior superior 1/3 of the gluteus medius. So this is the gluteus medius after we remove the Gluteus Maximus. And if you see here, you can figure out that really it originates from the ilium, where exactly between the anterior and posterior gluteal line. So this area is the origin of a Gluteus Medius, and you see here, of course, it cut and it inserted in the lateral surface, not in the medial, in the lateral surface of greater trochanter of femur. So now the innervation of Gluteus Medius and also to the Gluteus Minimus below it is from superior gluteal nerve. Yes, you remember that Gluteus Maximus was from inferior gluteal, but Gluteus Medius and Minimus innervated by the superior gluteal nerve. Now, the action of Gluteus Medius and also Minimus, they indeed abduct. That means moving the hip away, abduct, and medially rotate the thigh, and also, of course, maintains the steady pelvis during the walking. But most importantly, the Gluteus Medius abduct, because you imagine when it's contracted, it moves the hip away, so it's abduct and medially close to this area, medially rotate the thigh. Now, Gluteus Minimus just below it originates also from the inferior, from the ilium. If you dig deep in details, it originates between the anterior, because this is the anterior gluteal line, and the I would say here, okay, and the inferior gluteal line. So it originates from the ilium, yes, between the anterior and inferior gluteal line, as you see here, and it's inserted in the superior, in the anterior surface of greater trochanter. This is a greater trochanter again, so from the anterior surface of it. The function of it is very similar to the Gluteus Medius, so they share not just the function but also the nerve supply. So the Gluteus Minimus, that means it abducts the hip and medially rotated, and the innervation similar to the Gluteus Medius. This is very important. So they share the function and the innervation. Yes, this is a great figure, shows you, this is the Gluteus Maximus. Look at it here. We cut this part of the Gluteus Maximus to show you the other gluteal muscles, and in this case, you see the Gluteus Medius and the Gluteus Minimus. They are innervated by this nerve, superior gluteal nerve. You see the superior gluteal nerve? You remember the structure passing superior to the piriformis. On the other hand, this is the inferior gluteal nerve that innervates the Gluteus Maximus. Okay, so another small little muscle, which is anterior laterally, it's known as tensor fascia lata or tensor fascia latae. So the tensor fascia latae originates from the anterior superior iliac spine and the anterior part of iliac crest. And this little small muscle inserted in the iliotibial tract. This broadening of the fascia of the thigh, and of course you know that the iliotibial tract inserted in the lateral condyle of tibia. Yes, this muscle innervated also by superior gluteal nerve and maintain the knee in extended position, because you know, if the knee like flex, then when it's contracted, it pulls the iliotibial tract up and extend and keep your knee in extended position, so it maintains that. Yes, we finished the Gluteus Maximus and Medius Minimus, and now to the Piriformis muscle. I like this muscle. not because we talked about it that it divides the structures passing from a greater sciatic notch into structure above it and below it. No, but it also a little good muscle originates from the anterior aspect of the sacrum there, anteriorly, and inserted in the superior border of a greater trochanter. This is the piriformis muscle. This muscle, as I mentioned, divides the superior gluteal foramen into two compartments, above it and below it. So the structure passes above it or below it. And we will talk about the sciatic nerve and its relation to this muscle. That's why this muscle is important. It's in relation to the largest nerve in your body. So it originates by, remember, Piriformis S, S1, S2, the innervation, right? Piriformis S, right? S1, S2, and now you have to imagine the function. But there is a general rule, not just about the piriformis, but about piriformis, superior gemellus, inferior gemellus, and obturator anternus. So these four muscles, they share the same function, in which the piriformis and the other muscles, they laterally, if your thigh is extended like in standing position, so this muscle will laterally, these muscles, and specifically I'm talking about the piriformis, will laterally rotate the thigh when your thigh is extended. And if your thigh is flexed, like say this, so this muscle will abduct because it will contract. So once contract, it move it away, right? So let me erase this and make it clear and say this. The piriformis muscle and the other four muscles, they laterally rotate the thigh when it's extended. So laterally rotate extended thigh, and they abduct the flexed thigh. Of course, stabilizing with other muscle the hip joint by stabilizing, I mean the femoral head or the head of femur in the acetabulum. So other than the piriformis, we have obturator anternus. This muscle located between the two sisters, superior gemellus and inferior gemellus. The obturator anternus, as you see here, originates from the inner surface of obturator membrane. There is obturator foramen covered by membrane. So the obturator anternus muscle originates from obturator membrane and the adjacent bones, and it's reflected there to move laterally and inserted in the if you remember the trochanteric fossa here. This is the greater trochanter, just a little bit posteriorly there is a fossa here known as trochanteric fossa. So this muscle, as I mentioned, like piriformis, like superior and inferior gemelli, they of course laterally rotate the extended thigh and abduct the flexed thigh. Yes. Now reaching to the two sisters, superior gemellus and inferior gemellus. The superior gemellus originates from ischial spine. The inferior gemellus from the upper part of ischial tuberosity. So from ischial bone at the end of the day, one from the spine and one from the ischial tuberosity, and instead in the greater trochanteric, again in the trochanteric fossa with obturator anternus. Similar, we mentioned the function again and again, like piriformis and obturator anternus. The superior and inferior gemelli laterally rotated or the laterally rotate extended thigh and abduct flexed one. So now the nerve supply, it's gonna be like a little bit different, but it's interesting. Why? The superior gemellus innervated from nerve to obturator anternus, but the inferior, this is the superior gemellus. The inferior gemellus innervated from a nerve to quadratus femoris, right? So each muscle innervated from the nerve to the muscle below it. Yes. Lastly, we have a little small interesting muscle, especially in shape, which is a quadrangular shape that's known as a quadratus femoris. And in the quadratus femoris, guys, originates from the lateral border of ischial tuberosity and inserted in the quadratus tubercle here. If you remember do you remember the greater, we mentioned that, greater trochanter and lesser trochanter? In between posteriorly, there is intertrochanteric crest, and in the upper half there is of course quadratus tubercle, this tubercle. So the quadratus tubercle inserted there plus part of intertrochanteric crest, and this muscle laterally rotate the thigh. You imagine it will twist the thigh laterally, so laterally rotates the thigh. We finished bones already, muscles mainly. This lecture mainly about the muscles. Now let us cover the nerves, and briefly, because already will be discussed in another lecture about nerves of the lower limb, but let me mention those nerves in the gluteal region and the blood vessels. So I think you remember from the previous couple of slides when we talked about the structures passing from the superior and inferior gluteal, superior and inferior sciatic foramina. I think you remember that in the greater sciatic foramen, you have the piriformis that divides the structure, divides the structures into structures above it and below it. And you remember the nerve above the piriformis, which is the superior gluteal nerve, and on the other hand, you have one inferior to it, which is the inferior gluteal nerve. Okay, so you have superior and inferior gluteal nerve. What else? You have just directly before inferior to the piriformis, and we'll talk more about the exceptional cases. You have the largest nerve in your body, which is the sciatic nerve. What else? I think you remember the pudendal nerve, and you remember also the nerve to Obturator Anternus, and one to the Quadratus femoris muscle. But where is the nerve of Quadratus femoris? Let me erase all of these things and show you this. Yes, look at here, there is a nerve. It's like faint in color. It's like they're trying to tell you that this is not directed posteriorly. This nerve to Quadratus femoris, will, of course, it leaves the pelvic cavity through the greater sciatic foramen, but it passes anterior to the superior and inferior gemellus and anterior also to the Obturator Anternus. That means it passes anterior to these muscles, so you cannot see it from here until, as you see here, it reaches the Quadratus femoris, right? So these, of course, in addition to the cutaneous, posterior cutaneous nerve of thigh. So these nerves, 7 nerves in the gluteal region. Now let us shift to the arteries of gluteal region. In general, you have branch from internal iliac artery and branch from femoral artery, exactly from deep artery of thigh. From the internal iliac, you will get, as you remember, the superior gluteal artery and vein, and also you will get inferior gluteal ones, right? Those are from internal iliac artery. Now, to the blood vessels, you remember this large artery. This is the femoral artery, and superiorly it gives a branch known as the deep artery of the thigh that gives perforating branch 1, 2, 3, and sometimes 4, plus to the lateral circumflex and medial, this is the medial circumflex and lateral circumflex. Let me erase these things so then you can see what I'm saying, what I'm talking about. Let me use this pen. Okay, so these are the main arteries of the gluteal region. So superior gluteal, inferior gluteal, and from deep artery of the thigh, which is a branch of femoral artery, it gives the lateral circumflex and medial circumflex plus to the first perforating artery. So this is another view showing the piriformis and the blood vessel above it and below it, including the superior gluteal and inferior gluteal vessel above the piriformis and below it. And these vessels create a kind of anastomosis. So one known as trochanteric anastomosis and another one cruciate anastomosis. So let me start with the trochanteric anastomosis, and from its name, trochanteric, it's nearby the greater trochanter, exactly near the, I would say, the trochanteric fossa. This is the trochanteric fossa, should be here, right? So what the arteries that contribute to form this anastomosis, that known as trochanteric anastomosis? Very simple. Superior gluteal artery, inferior gluteal artery, right? Plus medial circumflex and lateral circumflex of deep femoral artery or deep artery of the thigh. Okay, 4 branches, right? Superior and inferior gluteal, lateral and medial circumflex. Very simple. But there is another anastomosis that known as cruciate anastomosis. It's known as cruciate anastomosis because the arteries are crossing each other like a cross, right? So let me show you the components of this. So first of all, the cruciate anastomosis occurs, I would say, near the level of lesser trochanter at this area, right? Not here, but here. That means you have to exclude the superior one. We will exclude the superior gluteal artery, and instead of it, we will use this artery, the first perforating artery. So the components of they form the cruciate anastomosis is inferior gluteal artery with a descending branch, right? Plus the medial and lateral circumflex, still they are the same, and ascending branch from first perforating artery. You know, the first perforating artery is a branch from deep artery of the thigh. There are a couple of names for deep artery of the thigh, right? Anyway, so let us erase this. So you will see that it creates a kind of, with the medial and lateral circumflex plus branch from here, from inferior gluteal, and the branch from perforating. So they create a kind of crush form. What's the significance of this I would say anastomosis? Yes, indeed, if there is, you know that the inferior gluteal artery is a branch from internal iliac. You know, you have a common iliac that divides into internal iliac and external iliac, and external iliac continues as femoral artery. Now, if there is a blockage between for example, a blockage in the blood supply of lower limb between the external iliac, for example, here, right, and femoral artery. So in this case, if there is a blockage here for a reason or another, you have an alternative way to blood to move from internal iliac, up to the, and anastomosis with the branch of femoral artery here, right? So then that means maintain the blood supply to the lower limb. Yes, we discussed that. show you a couple of bursae distributed in the gluteal region, and you will appreciate their location to decrease the friction there, in which again, let me let you understand what you look into the gluteal region from laterally, and here is the part of a gluteus maximus that cut in already, right? So to show you the bursa there. So you remember the we talked about the ischial tuberosity, in which you sit on it and it's separated from the skin by bursa, because when you sit, as we mentioned, you don't sit on the gluteus maximus because the lower border will be shortened or raised up, but you sit in the you sit in the ischial tuberosity, and there is ischial bursa here, known as yes, the ischial bursa, to decrease the pressure against the bone and the skin. Now this is the first one. Also, this one, I would say, the next one, I mean, the trochanteric bursa. The trochanteric bursa simply locates against the gluteus maximus, as you see here. We cut it, and the greater trochanter, so between the tendon of gluteus maximus and the greater trochanter. And the third one, which is the gluteofemoral bursa here, that's separates the iliotibial tract that you see here from the vastus lateralis muscle here. So these mainly the most important bursae there. Now that's why we discuss the relation of piriformis muscle and the location of the sciatic nerve in relation to it. So in order, and it's important to know where is the safest area, where is the safe area to inject the intramuscular injection. So this is the buttock, the left, for example, or the right. You divide it into 4 quadrants, and 4 quadrants, why? In order to get away from the sciatic nerve. So you have to move the outer upper quadrant, outer upper quadrant. So this is the safest quadrant, the safest area away from sciatic nerve, right, for the intramuscular injection. So you're gonna avoid the injury to the sciatic nerve. So this is the location of injection. So it's good to mention a test and sign known as a Trendelenburg sign, and this there are a couple of reasons to get a positive Trendelenburg sign, but we talked about the gluteal region and the gluteus medius and minimus. You know, these muscles are the abductor muscle, and when they contracted, for example, normally when you stand on one limb like this and swing the other, so the pelvis should not swing that much, should be balanced, should be adapted. So this is normal here, right? You see, they are the same, almost at the same plane. But if you have injury, for example, to the superior gluteal nerve that innervates, or injury to the at the end of the day, you have a paralysis or weak in the gluteus medius and minimus. That means when you stand on the affected side, say this is the affected side, when you stand on this limb, the affected limb, and swing the other, because these muscles are paralyzed, so they will not contract, so the hip will tilt to that way severely, you see, right? So it's explained here, the function of this muscle, how it's to, when you swing this limb, it should be contracted and make the hip-like imbalance way. So again, I would like to iterate the couple of variations in the location of sciatic nerve into piriformis, and not just for to take care when you inject the intramuscular injection, when you give the intramuscular, no, but also to another syndrome called Piriformis Syndrome. But let me show you the variation. Yes, more than 85% or more of sciatic nerve usually inferior to the piriformis, right? So here you go. Here you see, guys, that the sciatic nerve, because it has two parts, right? Common fibular one and tibial one. So two parts for sciatic nerve. Anyway, both parts of sciatic nerve passes inferior to the piriformis. This is most common, but still you have 12 or 13% in which the common fibular one, the common fibular branch of sciatic nerve, passes through the piriformis itself, you see? While less than 1%, which is rare, in which the common fibular, so always you complaining the common fibular, right? The common fibular passes superior to the piriformis, not through it, no, superior to it. That's why it's more liable or vulnerable for injury during the intramuscular injection or intragluteal injection. So again, because of the relationship of the sciatic nerve, as you see here, to the piriformis muscle, sometimes spasm of the piriformis muscle for a reason or another can create a kind of compression and pressure on the sciatic nerve here, in which this syndrome known as Piriformis Syndrome. So there is a compression on sciatic nerve created by sciatic nerve created by piriformis muscle. So they're trying here you have to imagine the sign of symptoms, which is very similar to the sciatica, and sometimes the patient not just has a dull pain in the hip area, but also can extend it from the back all the way until you reach the foot down, which is, as I mentioned, similar to the pain of the disc or sciatica, right? So this is you have to be aware for that. It's not always the disc. It's not always herniation. So sometimes you have to think about piriformis syndrome, right? Thank you, and I hope you find value in it. Thank you.